Hello, I'm Jess Creasy from Dementia Australia, and welcome to the second webinar in our series, Assessing the Quality of Dementia Care with Aged Care Quality and Safety Commissioner Janet Anderson. I'm joining you from Camaragal Lands in New South Wales, and I acknowledge and pay my respects to the Camaragal people, their continued connection to land and waters, pay my respects to their elders, past, present and emerging. I also extend that to First Nations elders of all through Australia and to any First Nations people joining us here. So thank you. Today's webinar will initially be a few words from the Commissioner, and then we will continue into a relaxed discussion on questions that we hope you can pose for us. For those of you who haven't used this particular communications platform before, in your top left corner there should be a Q&A button, which if you click the drop-down menu there will enable you to type in any questions or comments you might like answered or that we might put to the Commissioner. We have 3 Dementia Australia staff helping in the background to curate those questions, and any that require a direct response, they will do so. The others, they will publish for everyone to see, and I encourage everyone, not just the people writing the comments, but everyone to read those questions and comments. And if you see one that you like, or that you would like to hear the Commissioner respond to, please actually click on the like option there. And then the staff who are filtering the questions will actually take that as to gauge which questions to actually pass on to the Commissioner. So you'll be hearing from 3 people today, myself, my colleague Natalie, who will be asking the questions, and also the Commissioner, who I will pass to and introduce now. If you could please all welcome Commissioner Anderson.
Oh, thank you, Jess. As Jess said, I do have a presentation to provide to you, and I'm hoping the technology will be my friend. And I'll be able to bring it up. I'm trusting that that's on the screen now. The topic for this afternoon is the way the Commission, the Aged Care Quality and Safety Commission, sees quality and safety issues in home care and in residential care, and deriving from that some implications for people living with dementia. And I will endeavour to get through the slides with enough time to allow you to ask your questions and for us to engage in a mediated conversation, because I expect that there will be things that you want to share and possibly some questions to ask. So let me start with the facts, the statistics. This may be fairly familiar territory to many of you. There are around 2,700 residential aged care services across Australia and around 2,200 home care service providers. Now, the other statistics with which you may be less familiar are that in residential care services around Australia, around 70% of residents have moderate to severe cognitive impairment, and in the vast majority of residential services, over half the residents have moderate to severe cognitive impairment. So that suggests it's relatively equally distributed, as it were, as a population group, the prevalence of dementia in residential care. And most, not quite all, but very many residential services have at least 50% of the people for whom they're providing care who are in that cohort. So what does that mean? Let's just reflect very briefly on the implications of those statistics. You wouldn't be aware that people with advancing dementia experience difficulties with communication, with comprehension, with understanding sentences and instructions and guidance. They experience increasing difficulties with activities of daily living, and this isn't universal. And forgive me for generalising, because I think we lose sight of the individual when we go to the broad. But for the purposes of setting the context for the discussion to follow, their acts of self-care become uncoordinated and lacking in direction and a purpose, an objective. Many of them experience increasing physical impairment, they have difficulties in chewing and swallowing, general mobility issues with balance, flexibility, muscle strength. And then some have behavioural and psychological symptoms of dementia. It can be confusion, it can be depression, there can be a mental illness overlay, agitation, aggression, personality changes. So they can become less inhibited, and including in relation to their sexual urges and so on. Now, the implications of that are many and varied and significant, wide-ranging. They go to questions of the physical layout and the wayfinding opportunities and the auditory and visual stimulation or dampening that in some parts of a service in order not to confuse somebody who already has problems with processing information. They go to the effort that staff make to get to know the person, what they like, what sets their hair back, what they dislike, and what they intensely hate, as it were. What calms and settles them versus what agitates them or triggers them into a difficult behaviour. And so they need additional assistance, many of them, and increasingly with matters of personal hygiene, with grooming, with toileting, showering, with nutrition, assistance with meals and ensuring that they take meals and get the nutrition which is available to them, but also that the meals are appetizing and familiar and easy to eat and digest. And then fundamentally also social interaction and stimulation, which they won't be able to necessarily self-initiate, but which is so vital to their overall well-being. We are talking about the physical, social and emotional well-being of an individual who is experiencing a progressive neurodegenerative disorder and the impact that has on their quality of life, which can, to some extent, be accommodated and dampened by the work that's done by an aged care worker. And that's key. Now, I have a sequence of slides here, which I'm going to share with you, which haven't come up the right way. Okay, which go to the various things that we publish, various things that the Commission publishes about the sector. Now, this is the most recent report, which was January to March 2022, which we published in recent weeks. It's just a quarter, but it's relatively stable as a way of seeing the sector. So I chose just to share with you a single quarter, and I'll move through this fairly rapidly. Now, this is there's one that's missing there. It doesn't appear to be anything on that slide. I don't know quite why that is. Let's go to the COVID-related complaints. These are complaints specific to COVID-related matters. And as you can see there, the top three, visitor restrictions, concerns about preparedness and prevention, lack of communication. They are probably fairly predictable. And the fourth is infection control, equally predictable, and it drops way down. So as a proportion of total complaints, we have received a number of complaints which is specific in residential care to COVID-19, and visitor restrictions certainly leads the pack and has caused us to give very careful consideration to the deleterious impact of social isolation on everyone in aged care homes, and particularly people who have difficulties with cognition, people who are easily confused and don't have ready recognition of other people who are suddenly masked from the nose down and may even be further shielded. So this is one way of seeing the sector. I bring in these standards here because I hope all of you on this webinar are familiar with the standards, but I just wanted to preface my next comment by reminding you there are 8 standards, 42 requirements. Each of them is prefaced by a consumer outcome and then an organisation statement and requirements to follow. So when I put up the next slide, which is the number of services which were non-compliant when we went and had a look at them, and it's against each of the 8 standards. And I'm going to move through this quickly, and there's not a quiz at the end that you have to study and learn from. I'm trying to create a general impression of where we are finding issues with quality and safety in the sector. So for residential care, the lead out concerning area of performance is standard 3, which is personal care and clinical care. The next highest is organisational governance, standard 8. And then the third highest is human resources, which is actually about the staffing of the sector. But that perhaps also is reasonably self-evident. We undertake our assessment and monitoring both on-site and off-site. And when we're on-site, or indeed when we're off-site, we assess one or a number of requirements. But this is the way we see the sector. So where services tend to have greatest difficulty in meeting the standard, let alone exceeding the standard, is in that third standard, personal care and clinical care. Now, when you subset that, the top 10 requirements, 42 requirements, 8 standards, when you subset it, these are the top 10 requirements across the 8 standards where we are finding non-compliance. Now, I've color-coded them so that it's easy for you to understand, how many of them appear how many times. The keen-eyed amongst you will notice that 4 standards are present in this top 10. Standard 2, Standard 3, Standard 7, and Standard 8. There are 3 for Standard 3, 3 for Standard 8, 2 for Standard 7, 2 for Standard 2. So the 2 which feature most prominently are Standard 3, personal care, clinical care, and Standard 8, organisational governance. So again, no particular surprises, it matches with the general overview, and you can run your eye quickly down the list. What I'm going to ask you to do is to have in the back of your mind that archetypal individual with some degree of dementia, confusion, disorientation, difficulty in processing information. And if there were a compliance issue in relation to, for example, safe and effective personal and clinical care, then there's a chance it's going to go wrong for that individual. High impact or high prevalence risks, similarly, an individual with dementia is more vulnerable than somebody who is cognitively intact. The next slide drills down into that standard with the greatest level of non-compliance, Standard 3. And there are 7 requirements in Standard 3, and you can see each of them listed there, and you can see the proportions of non-compliance found against each of them. The 3A, safe and effective personal clinical care, is the standout. And as you can see here yourself, the next highest is high impact, high prevalence risks, and the third is infection risk management. Now, that is peculiar to the pandemic. We wouldn't normally see that registering quite so prominently on this list, but there are reasons for that we would understand. So again, you're starting to develop a profile of where services are getting things a bit wrong. Let's move to home services. This is very different. And I will try to assist you in making some of the comparisons as we go through, because unsurprisingly, where we find non-compliance in home services is quite different from where we find it in residential services. So the top 10 complaint issues, as you can see here, leading out the charge is lack of consultation or communication. Next highest is fees and charges. And in fact, financial matters features very prominently. There are no fewer than 5 in this list that are in the top 10 complaints issues, which are in relation to finances. Now, we think that's a bit skewed, and we're concerned to hear the voice of the consumer in home care about matters other than finance, but it does speak to their concerns and their anxieties around the value of packages and the way in which their package funds are being managed. But I'll call out lack of consultation or communication as the first, consistent client care and coordination as the fourth, and then down towards the bottom, care planning. That bracket of 3 is about engagement with the consumer and working in partnership with the consumer to co-design care and services. Now, we know that the incidence of dementia in home care consumers and in Commonwealth Home Support Program participants is lower, and that where dementia is present, it is less advanced. So we have a different client population consuming home care services, but they are still somewhat disadvantaged in self-advocacy, in bringing to attention where they might have concerns about some aspect of care. So it's vital that we understand the impact of these sorts of non-compliance issues on somebody who may not be fully able to represent their own interest in an interaction with a care worker, for example. Now, this is the reminder, this is a slide that was missing. This is the residential services profile. Do you see how different this profile is? Personal and oral hygiene is the first, closely followed by staffing concerns and then medication administration. So you see what's happening there. There is a stronger representation of clinical and quasi-clinical matters, which are the subject of complaints in residential care. And then there is sprinkled within those issues of staffing, where you see number 2 is personnel number and sufficiency, and then further down personnel behaviour and conduct. And then we have a visitors restrictions one. So it's quite a different profile, and that's probably unsurprising, but it does mean that we are on the lookout for different things, depending on whether it's residential care or home care, because of their differential impact on consumers. Now, still with home services, or back to home services, again, these are the differential between the 8 standards in terms of where we find non-compliance. Some of you may have already noticed that the same 4 standards feature here as in the list for residential care: 2, 8, 3, 7, but in a different order. They're actually differently ordered. 2 is far more prominent as a standard where non-compliance is found in home services than it is in residential services. Now, that's unsurprising. Look at standard 2, ongoing assessment and planning with consumers. This is where home care providers are not universally doing their best work. Now, if they are falling down on planning, then chances are they're not having discussions with the consumer about their needs and preferences. And if somebody is less able to advocate on their own behalf, then that's not going to go well for a person with dementia. Now, moving on to where we find non-compliance through our quality assessment and monitoring work, again, this is a very different profile. And what I've tried to do in the bottom left there is to give you an aide-memoire as to the profile for residential care. The top 10 requirements are, again, quite different. We have 2, 3, 7, 8 featuring here, but with different emphasis on each. And as I said in the earlier slide, with 2 being ongoing assessment and planning with consumers featuring most prominently. There are 4 of the top 10, and by the way, the eagle-eyed amongst you will realise there are 12 here, as I did when I was preparing this slide. Top 10, which is 12. 4 of those 12 are standard 2, 4 are standard 3, 3 are standard 8, and 1 is standard 7. So differently ordered because of the increasing focus and arguably importance that's placed on that planning, the assessment and the planning that must occur with the consumer. So this is the way we see home services, through this lens of non-compliance, if you like. Now, here's a slide which does some of the heavy lifting for us. It compares slides I put up previously separately, which is, so how do the 2 profiles work against each other? And it's not relevant for an individual consumer. It is relevant for a regulator because it guides where we pay closest attention. And it is different for residential services from home services for reasons which are self-evident. But what you can see is there's a reversal between standard 2 and standard 3. Standard 3 features very prominently in residential care. Standard 2 features with equal prominence in home care, and the reverse for the other one. Staffing, which is standard 7. Human resources features more prominent in residential care. Again, probably, predictably, because if you're short-staffed on a particular roster, then that is more obvious and can convert more quickly into a problem for consumers if call bell times extend and people aren't given the level of assistance they require in order to be safe and have a happy experience of aged care. The rest of it is roughly aligned, with the exception, of course, of standard 5, where service environment isn't something we would routinely assess in the home care environment. Now, there are other stats, and I know this is becoming a bit tedious for those of you who aren't numerically literate. Stay with me, it will end. But this is more statistics, more data which is reported by services on a quarterly basis. Quality indicators. They started a couple of years, at least 18 months ago. They have been expanded from 3 to a current 5. We started with pressure injuries, physical restraint, unplanned weight loss. 2 more have been added: falls and major injury and medication management. Further work is underway, both to expand the set of quality indicators. These only apply in residential aged care for the moment, and to extend indicators, a set of indicators yet to be finalised, into home services as well. because they give us another indication of how services are going. You know, what's going well, what needs more attention, what might need more assistance or support or direction from the regulator to ensure that everyone stays on the right track. And I put this up also because, as you can see, if you run your eye from left to right, and you can see the headings: pressure injuries, physical restraint, unplanned weight loss at the very top of the columns. The one which is most prominent, the one where you have the greatest prevalence of impact, is medication management. The next highest is falls. The other quality indicators have fairly low prevalence in aged care. And that's important to understand too, because as we go through these numbers, you'll think, oh, crumbs, you know, everyone is subject to this difficulty. No, it is always the minority. It's always less than half. But in some of these quality indicators, a larger proportion of residents are affected by them. So let's scoot through them fairly quickly. The first is, I put them in a different order because it works better in the presentation, but unplanned weight loss, the only thing you need to clock here is that it's around 9%. It doesn't seem to matter whether it's rural or metro. Around 9% of residents, and there's a particular methodology for recording and reporting, which is presented in detail in the narrative box, experience significant unplanned weight loss and consecutive unplanned weight loss. Now, I'm not standing here saying that's great, you know, as long as it's not 15 or 20%, we're good. No, of course we're not. That should be zero, but it won't be zero. Things happen in the best of services as they do in the worst of services. But what we do need to do is use this as a de facto benchmark. How can we get better and keep getting better than 9 or 10%? What is the path which takes us to a lower number, because we want to have as low a number as possible in those boxes? And the same thing applies, of course, with physical restraint. Again, you can run your eye quickly across the numbers. It's around, I mean, you know, depending on which measure, total physical restraint or physical restraint exclusively through secure areas. The total physical restraint is around 21%, but the number which is done in secure areas, which is a description typically of a closed unit, a secure dementia unit, is obviously a large proportion of that total. But again, how can we reduce that? That's an interesting number. Is that high or low? We don't have benchmarking data on this yet. We are looking to establish that over time. But you can bet that what we would seek to be doing is looking for ways of reducing the use of restraint and restrictive practices generally in aged care. And then the final in the set of three is medication management. And there are two sub-measures here. One is about polypharmacy and the prevalence of polypharmacy, which is high, and unsurprisingly so, because we have a population in residential care, as you guys know, which does tend to have chronic disease. These individuals tend to be on multiple medications for a range of body system problems. And then of greater interest from a restrictive practice standpoint is the use of antipsychotics. And at 20%, 1 in 5 people in residential aged care is reporting the use of antipsychotics. Only 10% of those, about half of them, have a diagnosis of psychosis where it is provided therapeutically to treat a diagnosed mental illness. The balance is arguably being provided for behaviour management, and that is a difficulty that we have to address and that we're on to already. Let me move to that. Earlier this year, I appointed a senior practitioner of restrictive practices, Kerry Hancox, and she recruited a restrictive practices unit. It is small and mighty. Its initial focus is internal to the Commission. Their principal job for now is ensuring that all my frontline staff, all my quantity assessors and complaints officers, compliance officers, serious incident response assessors are wise and well-informed and capable of understanding and responding to instances of restrictive practices. The new principles came into effect from July 2021, and this small unit is looking very closely and has already commenced a job of developing guidance for the sector and pointing providers in the direction of expert resources, of which there are a number, including Dementia Australia, where providers should go if they are experiencing an issue or challenge with an individual, or want to reset their staffing and ensure that they have access to the right skills and training to be proficient and competent in minimising the use of restrictive practices, and where necessary to use them, using them properly. So there are four areas that we see in relation to non-compliance on restrictive practices requirements. Misunderstanding of what is and is not a restrictive practice, and we do encounter that quite a lot where people are confused. So we offer a point of clarification, and there is guidance on our website to assist people in just clarifying what constitutes restrictive practice or not. Does consent make a difference? Tip is no, you must have consent, but it still may be inappropriate. And then lack of staff understanding and capability, that's the training piece. That will be ongoing. We're never going to sort that entirely. That will be a continuing obligation of providers as you induct, take on staff, supervise them. The training they receive will increasingly need to include a core component of options other than restrictive practices to assist an individual in achieving a quality of life and managing any behaviours. Minimum legislative requirements not being met. So this goes to restrictive practices sometimes being used as the first resort rather than last resort, and not being overseen or reviewed regularly, which would be the perfect opportunity to discontinue it if it was no longer required. And that doesn't happen often enough. And then finally, the legal requirement to obtain consent is sometimes overlooked or done poorly, and we need to call that out and ensure that providers are doing the right thing there. Now, the behaviour support plans was an obligation introduced in September last year, and we're finding that this is where the sector has a very significant lift to do. As a sector, we're not used to working with behaviour support plans. It's far more familiar in disability supports than it is in aged care. So we have to study. There needs to be a deliberate focus by providers on what is a behaviour support plan, what does it look like, how do we assemble it, and how should it be implemented, available for implementation and implemented by every staff member on every shift. And what we find is it tends not to be aggregated into a discrete plan, but it tends to be bits and pieces in a number of different documents, which means it is inaccessible for the next shift. So if they encounter some challenging behaviour by an individual under their care, then there's no plan they can go to online which says, oh, right, now Graham's triggered by, and the things which tend to settle him down are. That if that's not available, then that staff member is at sea. And no matter what skills they have, they're starting behind where they should be. So behaviour support planning, the process and the documentation are fundamental. And as you can see here, this is where we find areas of non-compliance. Inadequate information in the plan to actually assist a staff member in understanding what they should do in a particular circumstance or avoid doing in a particular circumstance. They're not meeting minimum legal obligations. It is generically formed rather than specific to the needs and preferences as they change over time of a named individual. It's not that person's support plan, it's a support plan for a larger cohort who's ill-defined, or it's absent when it's most required. That again is contrary to the principles in law, but it's not something, a behaviour support plan is not something you whip up when the behaviour manifests and is causing major difficulties for that individual and possibly others surrounding them. It's something in best practice you would anticipate as being a requirement or looking like it might be required. Let's get cracking now. Let's formulate the plan in the event that it is required. I know it's not always possible, and sometimes we can be taken by surprise by behaviour which comes out of nowhere, but in many occasions it can be foreseen, and it's something that should be worked on in advance of being required. So implications for practice. We look very carefully at the ways in which we can complement what is already available to the sector. We don't hold ourselves out to be the experts in behaviour support planning or in restrictive practices. That's not our wheelhouse. There are many others who do, Dementia Australia, Dementia Support Australia. There are many experts in this area, and there is much which is published, including international research and so on, that we would point providers to. I really do hope that this is something that providers understand is necessary to study. You can't just suddenly turn around one day and say, right, we're going to do behaviour support plans today. No, you actually have to prepare, take on knowledge, and be skillful in the way it's done, or they will be ineffective, and it will not be worth the paper and the effort that you put into it. So we are looking for these results. Change behaviours are identified and supported, so that where an individual is presenting differently or is acting in a different way, that is understood, and there is a support provided to them which is the least inhibiting of what they are seeking to do, but keeps them safe and keeps those surrounding them safe. Best practice positive behaviour support strategies are implemented. Collaboration and shared decision making occurs with the consumer and relevant others. People who speak on their behalf or authorised to speak on their behalf must be part of the planning. Practice and support strategies seek to reduce or end the need for restrictive practices. There will be occasions where they're required. And we need to understand that too. It is not a zero target here, but it is a target of minimising the use of restrictive practices, making every alternative available that can be explored and used, which proves to be effective. And then when a restrictive practice is clearly required, using it in accordance with the principles for the least amount of time under supervision with review and the least restrictive option that is available to you. Supports and care are person-centred, individualised, not generic. Generic won't cut the mustard, and provide safeguards and optimises the consumer's health and well-being, which should be underpinning everything else. Final set of slides. I take you on to the serious incident response scheme. These numbers are shocking in one sense. They're not standardised. They're not benchmarked. So you don't have a way of understanding high or low when you look at these numbers. You just look at the numbers and think, wow, they look high. They are high, and bad things happen in good services. And that is not me indicating any degree of comfort or acceptance of the numbers, because everyone on this webinar would consider that that speaks to a very substantial parcel of work which needs to be done by the sector, on the sector, to keep consumers safe and free from harm and allow them to experience a really great aged care service. Now, you might be wondering why unreasonable use of force features so prominently, and the very dense box on the left gives some account of that. It is actually a very broad category, which includes, as it says there, squeezing, grabbing, pinching, hitting, pushing, as well as more extreme examples of unreasonable use of force. So we tend to get a higher proportion of notifications there than in other parts of this list of 8 reportable incidents. I will draw your attention, if you weren't already aware of it, that there is an amendment to Standard 8, which requires every single aged care provider, as it says here, to manage and prevent incidents, including the use of an incident management system. That is on every single provider. Now, I draw that to your attention because there is a misapprehension that the Serious Incident Response Scheme is all about reporting to the Commission, and it's not. It is actually about a continuous improvement loop, and this deserves a webinar all on its own. But just start with number 1, ensure leadership and a safety culture, and then move your eye around clockwise. Respond to incident, record and report incident, analyse incident, implement actions, close the loop. So it's a plan, do, check, act sort of cycle. It's fairly standard. And the incident management system that every single provider is required to implement according to the standard will enable this for every single residential aged care provider. Now, I've called out where the notification comes in. It's a subset of 3. It is not the scheme, it is a component of the scheme. So just very briefly, this is the Commission in all of our powers and functions. We are sometimes misapprehended as having a singular job of finding where things are going wrong and calling providers out and imposing sanctions on them when they go wrong. We are so much more than that. We spend a lot of time on prevention. The publication and guidance we issue on the standards is of itself a preventative measure. We engage with consumers, we educate, we have an online learning platform, which I hope all of you are aware of and maybe some of you subscribe to, I hope you do. We then have the ability to detect through a number of means, and where we are concerned about unmitigated risk of harm to a consumer, we act. And we have a number of ways of responding. Some of them are in the red zone, but relatively few of them. It's very rare that we get to the top of our regulatory pyramid. Our happy place is the green, right down the bottom, where we educate, inform and communicate and resolve straightforward complaints. We will stay there as long as providers are willing to do the right thing and getting it right most of the time. But when providers head up the right-hand side of this triangle, we go up the left. So when they're getting things wrong and things aren't going well and consumers are starting to look like they are at increasing risk of harm, then we will start to take regulatory actions, moving through the yellow to the ochre, where you start getting sanctions and notices to agree. We rarely revoke accreditation to be an approved provider or indeed approval to be a provider. It would happen on a handful of occasions any calendar year. It does happen though as a power we have, which we will use if there is significant, persistent, willful non-compliance by a provider with the standards, because consumers are typically being harmed at that point, and we will not stand by and allow that to happen. So what do we do? And I use this to close as an example of the full range of the powers that the Commission has. We monitor and assess services against the Standard 8 requirement for serious incident response. We manage complaints. We manage the entire scheme. We provide guidance and education to the sector about the reportable incidents, what is in each of the incidents and what the provider obligations are in relation to managing the risk of incidents occurring and preventing it wherever possible. We take proportionate regulatory action where we find non-compliance with the requirements in the law, and we publish information about sector performance back to the sector in order that you, the providers on this webinar, see yourselves and can benchmark yourselves, can have discussions up to and including at the board level about what you're doing about serious incidents to reduce their risk of recurrence and to ensure that all staff are skillful in delivering safe quality care and a wonderful consumer experience to every single consumer, including that large and growing proportion of consumers who have some degree of dementia. Thanks, Jess.
Thank you very much, Commissioner. That was, as always, an excellent presentation. You have a way of taking a sea of data and then, for myself and the other data illiterates, transfer that and filter it down to some really meaningful, practical messages. So thank you very much. Now, if I can change the tone slightly and move to some questions that I'd be very interested in, our audience would be interested in hearing you speak to. The first one, and then I'll ask Natalie to read out the others that have been liked. And please, everyone listening and watching now, please do jump in, read the questions and continue to like them, and then we'll support the team in passing the right ones up. But Janet, I'd like to speak to what you might say to providers, what they could do to provide the culture and leadership and corporate governance to support the the delivery of quality dementia care. You spoke in the cycle there, in the yellow, number one, leadership and governance there, but then several steps later on that cycle, you had the delivery phases, and then slides later on the triangle, obviously sliding up and down. That is encouraging change within providers. And as we all know, change in any situation is challenging. So I'd be interested to know what you might say to them to do in terms of culture, leadership and corporate governance.
My answer, and it might surprise some, because leadership and organisational governance sounds like a boardroom conversation, right? But my answer is you start with the consumer. If a board doesn't know what the consumers think, a board is incapable of holding the CEO to account for delivering the right outcomes for the organisation. So a board and a CEO should make it their business to understand generally the consumer voice, to hear it. And I'm not suggesting that you have to spend hours and hours of your time interviewing every single consumer, you know, on a fortnightly or monthly basis. That's not what I'm saying. But if you are deaf to the concerns and interests of consumers, then you will not be doing your best work. And in particular, where somebody has dementia and is unable to speak on their own behalf clearly, talking with family members and understanding the world from their perspective. What is it that they welcome about mum or dad's care? What is it that they are concerned about in respect of mum or dad's care? Are there things that you can work on with them? Are they looking for increased access to mum or dad on a less restrictive basis than might be the case under COVID in order that they can assist with feeding? You know, what is it that will enable the best quality care and experience to be had by every consumer? And leadership and governance has to be animated by that concept. Now, clearly there is a skill set that attaches to leadership and governance, and leadership is fundamentally about vision and mission, motivation, inspiration, creating meaning and a sense of direction, but it's also about culture. It's about developing the culture of the organisation. What do staff understand is not just permissible, but enabled. What is going to excite a manager about what the staff does or doesn't do? And if they know that, if it doesn't have to be reiterated as a lecture, but rather is assumed knowledge, I turn up to work and I know that this is expected of me. That's culture, the way we do things around here. And if leadership and governance can have squarely in mind cultivating a culture about a learning organisation and doing their best work every time they show up for work, that takes you a long way into delivering safe quality care. The only other point I make, and I know it's a long-winded answer, but it's an intriguing question and one that everyone should have top of their mind. Getting to know the individual, getting to know the consumer population is important in and of itself, but staff must be expected to know individuals. Staff must be expected to know more than their first name and what their daughter calls them. Staff must take the time, and it's not hours and hours, it's literally in the glancing moments of interaction with a consumer that you learn that they were a horse riding champion in their youth, or you learn that they served in the Korean War, or you learn that they can't abide broccoli. Whatever it is, you learn a bit more about them. You learn about them as a person, because with advancing dementia, you lose that opportunity. But if you know that about them, you will always have in your mind the person in front of you rather than somebody for whom care is being provided. They have an identity, a unique identity.
Thank you. That's an excellent answer, and I think it does speak to the person-centered care and actually understanding that care recipient's story and making that central to the actual care delivery. So thank you very much for that. And Jenna, I might move to Natalie if we have another question that the audience has put to you.
Hi everyone, thanks Jess, and thank you to the Commissioner. Just wanted to ask a couple of questions that have been highly liked. One of them is about, as residential aged care facilities don't prescribe, how is the Commission engaging with the GPs to educate them on the requirements that we are held to, and often failing the standard is one of them. And another popular question is also in relation to, in terms of achieving high quality care in residential aged care, is there a recommended staffing ratio in high care dementia units and not-for-profit sectors as well? And does this apply to Victoria?
Gee whiz, that's a specific one. Okay, all right, in order. We are That's a fair question in relation to engagement with GPs. My first answer is one that takes your question in a slightly different direction. We've issued very specific guidance about the obligations of providers to engage with GPs. You don't employ them. You rarely have a contractual relationship with them, though some of you do. They come in and they have what they call patients and we call residents in care, and they deliver primary care to those individuals who are their patients. But of course, any consequences of a consultation fall to the aged care staff inevitably to implement, whether it's a change in medication or some other practice which has been recommended. So the provider is a key stakeholder, and the staff are key stakeholders in all that primary care provider, that medical provider, does in their interaction with an aged care consumer. So my first answer, which is not the direction in which you were heading the question, is that we actually put a lot of expectation on the provider to have those conversations with GPs. You are the one, or your staff are the ones who encounter the GP often as they do their rounds if they have more than one patient in the service, and you are also the ones who read the notes to the extent that something is written up and have to implement whatever the GP has recommended. So you are the ones with proximal opportunity and should be taking full advantage of that to have the conversation with the general practitioner about their prescribing decisions. Then you were asking, what are we doing? We have had conversations with the college, RACGP, which were fruitful and useful, but probably were not taken far beyond that. The college gave us certain undertakings, and we're not sure about the extent to which the messaging went out to GPs, and indeed how many general practitioners are members of the college and paying close attention to the information which is coming from the college body. We have plans for further engagement. The Chief Clinical Advisor for the Commission, Dr. Melanie Roth, has an ongoing discussion with senior representatives of the college about these matters. We have also had direct engagement with primary health networks, and as you would know, there are 30 or 31 of those across the country. I hope you're reasonably familiar with their geographical catchment, and if you're a provider, you know which primary health network you sit within geographically. They clearly have a lot to do with local general practitioners, and there is important messaging we're also putting out through them in relation to medication management issues generally, and specifically on questions of consent. So that is something that we continue to work on. But please don't take three steps back. Providers are very much in frame for this as well. Second question, the short answer is no. There are no recommended staff ratios for high care recipients. We don't go in for ratios. You may be aware that the former government and the newly elected federal government have both said things out loud about care minutes and registered nurse minutes as a proportion of care minutes. That is the direction in which the system is heading. If you haven't come across that yet, if that's news to you, you might just want to Google it to get a broad sense of the direction in which the system is travelling in that regard. There will be expectations placed on providers in terms of reporting on average care minutes per resident per day, and the expectations will be promulgated by the government. This is contingent on the passage of legislation through Parliament, and my understanding is the government's rather keen for Parliament to consider that bill in coming months. So it's not yet the expectation, but it is definitely the direction in which the system is heading, and it would be worth the while of those on this webinar to do a bit of pre-reading just so you know what's coming. Thank you.
Thank you. Excellent. Very interesting there how you are able to bridge all the way from the care recipients up through into some large national bodies such as the GPs. In that vein, I'm curious how the Commission supports people who can't advocate for themselves, people living with dementia who can't necessarily advocate for themselves, who don't have family or carers who will do it on their behalf. But also then if there's advocacy you do on behalf of providers. And then back to Natalie. I know there's another question.
Right. We don't have a role in advocacy for consumers. I know, Jess, you were asking about providers. We point providers in the direction of advocacy groups such as Older Persons Advocacy Network, which has a growing footprint across the country. And if there are any providers who haven't yet had contact with OPAN, I actually would commend to you the action of reaching out to them and saying hello. They are really a powerful group. They are very effective. They are very skillful in supporting the interests of those who are uncertain about the way in which they would advocate on their own behalf. Just need a little bit of, support in possibly approaching a provider, or possibly have no one else in their lives, which goes to your question, Jess, about to advance their cause. We understand in the Commission the risks that people who don't have social networks, don't have family outside their aged care residence, are at heightened risk of being overlooked, particularly by busy staff who are just trying to do as much as they can for as many people as possible in the course of a shift. So somebody who is sitting quietly and not in a position to make requests or offer comments on the way things are for them may draw less attention, and they are somewhat disadvantaged in that whole scheme of things. Similarly, and possibly even in a more pronounced way, for home care recipients. And there is a notorious and truly ghastly a case that is known in South Australia in the disability support area, where an individual who was high care needs, single care worker, so single provider, no social network, and who died prematurely and very tragically as a result of what appears to have been neglect. And this was not known by anyone because there were no eyes on. So we are very exercised by the increased risk posed to individuals who can't speak for themselves and have no one else in their lives. Where they're a family, it is often the case that family are very well-equipped advocates or find some assistance to do that work. But where an individual is socially isolated and doesn't have family, we pay particular attention to that category of consumer when we do our assessment and monitoring. And we try to sample people who may be able to speak for themselves, hopefully have some ability to articulate any concerns they may have. The ones that we are least able to access in terms of a voice are those who have advanced dementia and really have lost the powers of communication or cognition and really aren't able to represent their own interest, where we then rely on the staff and the staff's reflections on the way in which they interact with that consumer and what seems to work for them. But it's an approximation to good because it is a highly challenging circumstance.
Yeah, I think that the challenge is acknowledged by everyone involved. It is tricky. But I'll pass straight to Natalie. We have about 5 minutes remaining, so we can try and squeeze in one, possibly two brief questions.
Okay, thank you. There's a really long one that's come in, so I'll try and summarise it. In a situation where a resident has been transferred to hospital, the hospital risk has assessed the person and that they need to arrange extra security officers. When that person then returns to aged care, they don't have the opportunity of security officers and often non-bodybuilders, as the person has asked. How is the Commission looking to support providers with these acutely high-risk residents when often they're spending a lot of their time trying to fill in the paperwork to prove why they need the extra support?
I'm not sure of the basis of the question. How do we support the providers? It's up to the providers, and it goes back to Jess's question about governance and leadership. It's up to the providers to understand what they take on when they take on responsibility for delivering aged care. Now, I am very sympathetic, and I say that with great sincerity. I am very sympathetic to the challenges that aged care providers experience. I understand them acutely, and I see them coming across in all manners of intelligence that we get about providers in the sector. But it is up to the provider to understand what the behaviour is and the best way of managing that behaviour. If it appears impossible, if there are too many risks attached to managing an individual in a particular setting, then other decisions may need to be made. And that would obviously be a discussion with the family where the family's involved. But we would need to see evidence that effort has been put to finding the expertise, drawing in others who know about managing challenging behaviour and can provide the specialist input to those less skilled staff to see how they can manage that. And if a restrictive practice is required and it's appropriately instituted, then it shall be used. We need to have a very clear understanding of what the rules say and then navigate our way through the rules in the interest of getting the best outcome for the consumer and those who surround them.
Thank you. And Jess, do we have time for one quick last question?
I think if it is a quick question, we might be able to speak. And if I could, Janet, please just a nice tight answer. Thank you.
No worries, thank you. What strategies can home care organisations realistically put into place to achieve this level of quality care?
That's not a quick answer. That is another webinar series, and my recommendation is go to our website, have a trawl through some of the guidance and advice which is there, and if you have particular questions that are really exercising you, about which you have significant concerns because you're not sure how to manage yourselves to deliver these sorts of outcomes for consumers, come and talk to us or talk to a fellow provider. Reach out laterally to your network and say, hey, we've got a puzzle here. We don't know how to do this well. Can somebody else help us? We're trying to encourage this networking across the sector so that you are building on each other's successes and you can identify and reach for excellence within the sector yourself, and you don't need the regulators to point you in that direction, though we're more than happy to help. Thanks, Jess.
Thank you, Janet. That's excellent. I think it speaks to the importance in any workspace of creating kind of a psychologically safe environment for staff to try things, to know that they're supported and from other providers, from their colleagues, and most certainly, and most importantly, from their supervisors and their employers. So thank you very much. We'll, pardon me, we will bring this to a close now, but it's been a fantastic presentation and a great opportunity to speak with you. Before I formally close, I'd like to just let everyone who is attending know that a link to recording this webinar will be posted, emailed out and available on our website in about 30 days once the actual producing team have tidied up and edited it. Certificates of attendance will also go out within about a week, and most of you, all of you, hopefully should just already have received an email with a link to a feedback survey. And we really value you taking a few moments to actually fill these out so we can better inform and amend our future presentations and webinars. So finally then, a thank you. First to the Dementia Australia staff who helped produce this: Taylor, Jim, Natalie, Amanda, Claire and Alianne, although I don't believe she joined us today. And finally to yourself, Commissioner, thank you very much for your time. It's been a real honour to have you on board.
My pleasure. Thank you.